Welcome to this morning's breakfast meeting. My name's Sally Warren. I'm the Director of Policy here at the King's Fund, and I'm delighted to be joined by our panellists this morning, but also by all of you to discuss delayed discharges and how to solve a problem like hospital discharge. Hospital discharge, delayed discharge is a real challenge for the healthcare system, but it's also really importantly a real problem for individuals who are therefore, because of delayed discharge, left in hospital when they could be better cared for elsewhere. So quite often when we talk about delayed discharge, it can be a real focus on systems, a real focus on, is the problem inflow within hospitals? Is the problem capacity in the community to be able to support people? And we can get quite carried away by talking about systems and processes and forget that this is really about people. So as we start today's session, where we are going to be reflecting on a piece of research that the King's Fund has done, but also then have contributions from local leaders who are grappling with how to really solve a problem like hospital discharge, it's important that we remember that people are at the heart of why this is important for the health and care system to be able to resolve. So I'm looking forward to this morning's session. A few little bits of housekeeping from me before we get underway. So some kind of tech bits of housekeeping. As you've joined as the audience at the moment your cameras and microphones are turned off and muted. That's to make sure that everybody in the call can hear and see all the speakers this morning. Once we move into the Q&A section, we will enable people to be able to turn their cameras and microphones on to ask a question. So you won't just be seeing the 5 faces of the panelists throughout the next hour and 15 minutes. You'll get to see some other faces and hear some other voices. As I say, that will be turned on shortly. As we kind of go through this morning session, please do ask questions using the Q&A function. That is along the top banner in your Teams function, the little speech bubbles with question marks. That's a Q&A function. Please do pop questions into that, and I will use the questions that are kind of put there to then invite people to contribute. So if your team's name isn't obvious, then please do pop your name in alongside your question as well, so I know who to be able to call to for questions. A few other bits of housekeeping. We have a hashtag if people would like to be using social media. Obviously, there's various forms of social media available now, and the hashtag is KF Solve Hospital Discharge. We are also, all of this information was in the joining instructions when you join the meeting. But we will be recording the session and sharing it afterwards with all of you who are attending this morning, but also those people who were invited and not able to join us this morning. So please, just a reminder that by joining today's call, you are giving us permission to record you in today's session. And if you make any contributions, those will be recorded, and you should consider anything said today to be on the record, because some colleagues from the media have been invited and will be present. So please do remember that. Hopefully we will still be having a full and frank conversation throughout the morning. So I think that's it from the point of view of all the housekeeping. So in terms of how today will run, we've got a really great panel that combines national perspectives, local perspectives, and then perspectives of research and evaluation. So we'll hear from each of those in turn in terms of setting out their opening remarks. We'll then have a bit of a discussion between myself and the panelists before we then open to Q&A, and we are aiming to have you all on your way by 9:45, so you can join other meetings throughout the day, whether you're in the office and running from meeting room to meeting room, or sat at a desk and pressing leave and join buttons on Teams throughout the day. So we will be on our way by 9:45. So that's all of the logistics and housekeeping. As I said at the start, delayed discharge is a really important issue for patients who are being looked after by the health and care system, but also in terms of really how it's a real emblematic of how the health and care system as a whole is working, how well we can be supporting people through their journey in hospital, and then from hospital out back to being supported in the community, in their own home, or in other settings in the community. So a really important issue. We were delighted at the King's Fund to be able to do some research having been commissioned by the Department of Health and Social Care to look at the Adult Social Care Discharge Fund from last year and what the experience of that and to what extent that helped or hindered or could be improved in future to really be able to support local efforts to improve social care discharge. So I'm going to start off the panel contributions by asking Simon Bottery, a senior fellow here at the King's Fund, to explain more about the research project. So Simon, over to you. Thank you.
Thank you, Sally. Yeah, as you say, we were asked by the Department of Health and Social Care to look at 2 tranches of funding last winter that were aimed to help resolve hospital discharge issues. The Adult Social Care Discharge Fund, which was worth 500 million, and the Hospital Discharge Fund, which was worth 250 million. And our job was to look at how systems experienced those 2 tranches of funding, what they felt about them, how they spent them, any issues that they had with them. I guess, like most pieces of research, really, you find things that you sort of expected to find but are interesting, and then you find things that you weren't necessarily expecting to find, and they're really, really interesting. So in terms of the things that we thought were interesting but not massively surprising, what we found from systems is that they really struggled with this issue of receiving annual tranches of short-term funding to spend on hospital discharge. I mean, the irony is that we know this is a long-term issue. You know, in the report we talk about National Audit Office talking about delayed discharges problems like 25 years ago and citing it then as being costing the NHS £1 million a day. So we know this is a really long-standing problem, but we also know that we have a tendency to try and deal with it by giving systems amounts of money on an annual basis at short notice. So there's an issue there, I think, to begin with. This was particularly short notice. Systems received notice of the hospital of the Adult Social Care Discharge Fund money in September 2022, and the hospital discharge funding wasn't actually announced until January 23. So this is money which is to be spent in winter, which in one case is being provided and announced sort of when we're already well into winter. It's not simply an issue for the systems that this is a bit inconvenient to get money at short notice and quite delayed. The issue is that how do you actually plan? How do you think ahead? How do you make decisions about how you spend the money when you don't actually necessarily know what you're going to get? And what we found is it tended to entrench existing ways of spending money rather than allow systems to sit back and think, okay, if we in an ideal world, how would we sort out hospital delayed discharge? How would we spend the money? So short-term funding and short notice were 2 of the sort of things that we heard. Also, perhaps again, unsurprisingly, there was concern about the limited criteria about what the money could be spent on. Not so much actually with the Adult Social Care Discharge Fund, which was quite broad. The issue there was that systems weren't allowed to spend it on preventing admissions in the first place, and many of them really wanted to spend it on that, but the criteria didn't allow them. But other than that, it was actually quite broad. Hospital Discharge Fund, less so. That 250 million, 200 of that was spent essentially on step down capacity, so it was really quite narrow in terms of what it could buy. And again, that caused problems for systems. Systems, for example, who had a strategy of trying to encourage and develop the home care market, finding themselves in a position where really they were being offered money to spend on beds. And then the final issue that didn't again surprise us enormously was about the onerous reporting requirements. The Adult Social Care Discharge Fund, the reporting was fortnightly. It was asking for details and information that didn't typically come out of the existing system, so people had to generate the information in order to send it off to the department. And the Hospital Discharge Fund actually had daily reporting requirements, so really very, very onerous indeed. None of that enormously surprising. What I think was more surprising for us was when we talked to systems about what caused delays, the range of reasons, I think, surprised me. Certainly, we asked them spontaneously, you know, what do you think are the causes of delays? And we were told about sort of over 20 things came up spontaneously that ranged from traffic issues with local hospitals to pharmacy issues, from lack of home support to poor planning administration. Often, in fairness, however, underpinned by staffing sort of striped throughout the reasons that we heard about delays, whether that was staffing in terms of home care support or whether that was staffing in terms of not having the ward capacity to actually do the paperwork and get people out quickly. Staffing was often one of the issues, and often it seemed to us is that the diversity of the reasons for delay stem from the diversity of the systems that we were looking at. So we were looking at 6 systems which were very different in terms of the size, the geography, the degree to which, you know, the local authority was coterminous with the ICS. Really quite different systems, and they'd got different health and care infrastructures which had developed over time. Some of them had NHS performance issues, some of them had local authority performance issues. So the diversity of the systems, it seemed to us, to some extent, fed into the range of reasons that were cited for delay. But what really surprised us, I think, was that when we asked the different partners in the system, and we talked to the acute trust, we talked typically to the DAS, we talked to a senior officer from the ICB, and we also talked to the Care Provider Association at a local health watch. But when we talked to system partners about what was the main causes of discharge delays, we got really very different answers, and often sometimes contradictory answers. So, you know, for example, I remember we sat with an ICB, and they told us, you know, when I sit with my trusted health colleagues and ask, they will say that the main cause of delayed discharge in our area is a lack of home care capacity, and I can tell you that that's not the reason. So we heard this pretty consistently. Some systems were better than others. Some systems did have more of a sense of it, but generally there was this lack of a really sort of joined up, agreed analysis of the causes of discharge, which meant therefore that it was actually really hard to come up with a plan for, well, what do we spend the money on to actually tackle it. And then I think probably even more surprising than that lack of agreement, typically, was that it was in contrast to what the systems told us about integration and relationships. So they pretty much to a person told us that they got on well as systems. The trust, the ICB, the local authority, they said they got on well, they had good relationships, and so they had this language that things were going well and they were integrating effectively and working together effectively. But below the surface there were these tensions and these disagreements which, you know, in many cases weren't being resolved. In some systems clearly they recognized it and were trying to address it more extensively than others, but in many of the systems it felt that, you know, that wasn't being done. It wasn't being tackled in the way that you might expect it to be tackled. So in summary, I guess the lessons we take away are, I think, that there are opportunities both for central government and for local systems to improve how we deal with delayed discharges, and really they're the reverse of the things that we found. Moving away from the system of short-term, short-notice funding, what someone said to us was, was regular, repeat funding every winter, moving away from that towards better underlying support, so that systems can plan more effectively. And then for systems themselves, it seemed to us getting this shared common understanding of what the issue is in the system, and that allowing a more joined up and a more sort of coherent and a more coordinated approach to tackling it. Sally.
Right. Thanks very much, Simon. A really helpful and clear summary. As you say, some findings which might have been predicted, and then some slightly more surprising findings. I think particularly as we talked there about some of the surprising findings were about local systems and local places where there perhaps wasn't the shared analysis and understanding of the causes of delayed discharge. We're now going to come to hear the reflections of a couple of local leaders. So I'm really pleased that we're joined by Becky Wilkinson, who's the Director of Adult Social Care at the City of Wolverhampton Council, and Matthew Kershaw, who's Chief Exec at Croydon Health Services NHS Trust and the place-based leader for health there. So they're both very generously going to share their local experience about how they've been able to really think about delayed discharges in a joined up way, how it's been able to challenge and improve how they work with partners. So Becky, we'll come to you first and then come to Matthew. Thank you for joining us this morning.
Thank you, Sally. Good morning, everybody. And a lot of what Simon's just said did really resonate with me, especially around some of the short-term funding issues. But I think where I would probably like to start is that relationship side of things. I do think in Wolverhampton we've worked really hard at getting the relationships right, and in contrast, I suppose, with the short-term nature of the funding, there's a real long-term journey around relationships, and it's something we've gone on in Wolverhampton. We've done a lot of development with our partners, with our ICS partners, and with our Royal Wolverhampton Trust partners. And I know it's really hard when you've been through a really tough winter and everybody's feeling a bit battered and bruised. But one of the things we made sure we absolutely did in March this year was assess and look at the impact of all of schemes we'd put in place last winter. It was something that we really had to drag ourselves to do because we'd had 28 schemes that we'd put into the last year's winter plan, and it was really important to take all the learning, what went well and what did we actually not want to do again this winter, what was a bit of a waste of time. And it's trusting ourselves really to know our own area. So we did a whole summary of the 22-23 winter plan, which then meant this year, when we started with 23-24 winter planning, we knew by July, for example, what we were and weren't going to put into the Adult Social Care Discharge Fund, which we'd ring-fenced at the beginning of the year. So I think there is something about trusting yourself and not instantly firefighting when you get the pots of money, the short-term money. We all know what works for our area, and we bit the bullet a little bit, and we looked at our data. We agreed. I think it's quite important early on to agree what data sets you're going to use, and it's probably fairly nice to Eskimos in terms of saying that, but quite often we really start fighting over the data and interpreting it in different ways. So I think agreeing that data set and agreeing what the data set is telling us is really crucial. So what we were able to do this year was realise very early on that one of our blockers to discharge was bariatric care. And we could see from last year, whilst there was only a few, it created quite incredible delays and also cost. So we took a bit of a long-term approach to that and spent the last 12 months widening our doorways in our own rehab centre, our local authority rehab centre, getting our staff trained up, getting the right equipment. And it was our health partners that did our training and sourced the equipment for us. So this winter, we've been able to open bariatric care from a social care perspective in our bed-based unit. So that's one thing we've took from last year, learnt and then implemented for this year. Commissioning the market was a big lesson last year in terms of making sure we didn't come up against our procurement colleagues who were not happy with last minute very high levels of spend that we're out with of our procurement laws. So enabling that spot purchase procurement in the run up to knowing that we were going to need it was something we learned last year as well. So we made sure we've got that in place for this winter. Understanding that it's not just a general bed blocking issue. I think quite often people out there who don't have access to the data assume that quite often it's older age people that are blocking beds. For us, we knew it was neuro and complex patients that we couldn't actually just put into residential care, and we needed a different solution to that. So we had 12 months of working on what we could do to create that space as well. I think agreeing your aims as well before you actually start getting your plan underway. So we we agreed our governance, we agreed our aims, and predominantly to ensure that Home First remained our default and preferred option, that all partners were bought into that, was really important to making sure the plan was the right plan. And whilst picking up on Simon's point around the money and the constraints around being all related to discharge, it is really important to think about the fact that we won't have the discharge problem if people weren't admitted in the first place. So again, learning from last year in terms of who are the most vulnerable in the community, who's got the most challenging needs, and who's most likely to need our support over the winter, and then looking at a place-based response to that, including the ambulance service, so reducing the need to convey to hospital at the same time as focusing on what we do to discharge people. Again, I think I've just touched on the governance, so having a place-based winter plan that we used our urgent and emergency care strategic working group, so it was chaired by our Royal Wolverhampton Trust and contributed to by myself and other colleagues in the ICS, and we did it in a real One Wolverhampton way. So I think there's a lot about being prepared, and I think we know and we have known for the last few years that the money that's come in winter has been short-term funding, but we know it's always come. So there's something about just thinking about your local area and knowing that it quite likely will come, as it has done, and what you're going to do to be ready for it. For me, it's insulating your area, because you know what's best for your area, and it's trusting yourself to go with that. Looking at what alternatives that we've got in place, looking at effective discharge, what needs to be in place around the transport, thinking about or like getting into the detail around TTOs, making sure everything is thought of. But really for me, the big thing that's helped this year has been having that long-term run up to it, and also agreeing the values and principles that we're all going to work within. It's really difficult when things get tough. We've been in and out of level 4 recently. People are under pressure, and it's just recognising how we behave as partners towards each other, which probably sounds a little bit fluffy, but it's been really important to us throughout the year. We've done regular development sessions, so we are going into this as one system team. We do One Wolverhampton development. We have our monthly board meetings. We did a wash up after winter last year, and we started getting assurance for our plans by July. So I think that the biggest lesson for me is give yourself time. So we're ready now. We've got our winter plan in place. We implemented it in October, but if anything else does come our way, we've got schemes already scoped out that we will implement and have ready to go. So I think that's been the key learning for me, is the planning, capture your learning, and then don't reinvent the wheel when winter hits.
Thank you, Becky. That's really, really helpful. And I think some really interesting kind of different types of approaches there, isn't there, in terms of what is it where you need to get the mechanics right, in terms of, do you know your data, do you know what the data is telling you, have you got a procurement strategy in place to be able to move with agility, but then also the really important side of things about how do you create a team across different organizations where you're genuinely teaming. So the kind of points around values, behaviors, trusting each other and trusting yourself is, I think, a really, really important side of that. So thanks, Becky, really helpful. Just before I hand over to Matthew to hear his local reflections, just a reminder to people that you can pop questions into the Q&A function, which you can find across the top of Teams. The chat function is disabled for this meeting, but the Q&As, you can pop questions into any or all of the panelists through there. So, but Matthew, we've heard about the Wolverhampton experience. What's your reflections from Croydon? Thank you.
Thanks, Sally, and good morning, everybody. Yeah, I'm going to give a few thoughts on the situation here in Croydon, and it has a lot of similarities to that Becky's just talked through. I would absolutely endorse the point about relationships. They are all. I'll come back to that a bit in a second, because there's no doubt that delayed discharges are a real issue, and what is abundantly clear to all of us, I don't think this is news for anybody on the call, is that it is truly a multifactorial issue. You know, if this was simple, you know, there's a problem here, let's identify what that problem is and then fix it, then we'd have dealt with this a long time ago. It is a lot more complicated than that. And we have everything in Croydon that everybody else has. So we're not unique in any shape or form in terms of this issue. I'd like to feel we were unique in many other ways, but on this particular issue, you know, the context that we have from a social care perspective, from an in-hospital set of issues, and indeed from the population that we serve, family issues, etc., they will be no different to anywhere else in the country. So what we've done is replicatable in that sense. And again, I come back to the point that a lot of this starts and ends with the working relationships you have amongst your teams. We have acknowledged the problem, as everybody has it, but we're looking at doing something a bit different to progress it. And I guess that's what I wanted to specifically talk about this morning. And I make that point because we have done, and in many ways continue to do, similar things to everybody else and things that we've always done. So we have a MAID event or a reset week. We brought staff and sat them together. And what we've basically found is that in and of itself, that isn't enough. It's not that those are worthless things. I don't think that's true. But are they going to fix the problem? Well, if they are going to, then some miracles going to need to happen because they haven't fixed the problem thus far on the basis that I've certainly done that in a number of places that I've worked, and it hasn't shifted the dial enough. That's quite likely because the situation is getting harder to resolve. The issues are getting more embedded, more complicated. The finances are tighter, the staffing numbers and the situation with staff is getting tougher, and as a consequence, things that, you know, we've all done before that haven't completely worked are going to work even less going forward. And so we have really acknowledged, and I think really importantly, that what good look like needs to be different, and we know we need to go further, and we need to be honest with each other and say what we've done so far hasn't been enough, and that we are committed to working towards trying to do something different in the future. And that's where our work on Frontrunner came in, and that's what I wanted to just briefly talk about now before handing over to colleagues. So we're one of 6 pilots across the country on the Frontrunner programme, which we received some support funding and sort of a collaboration, short sharing exercise with colleagues up and down the country. And the first starting point for us was to acknowledge that we were really in this space a bit on crisis intervention mode, whereas we needed to be on proactive prevention mode. And we thought about that in the context of what we've done in Croydon in terms of working together, because over the last 6 years we've had something called the One Croydon Alliance, which is a statement of intent supported by a memorandum of understanding between the various parties in health and social care across Croydon. So that's the Acute and Community Trust, that's mine, the old CCG, which obviously now is part of the ICB, which I also have a role in as place-based leader for health, but also our mental health trust, our social care teams, our local authority more generally, and the voluntary sector as well. And that alliance has led our collective work in a number of areas, one of which was on something called the Living Independently for Everyone initiative, so the LIFE team, which is an integrated community team where we have rehab staff, reablement staff, intermediate care teams, social care and community organisations all working together to try to improve discharge and support patients at home. And you might say, well, you've got all that and you've worked together for 6 years, why haven't you fixed it? Well, I would refer back to my previous comments because this is really complicated to do. And I think acknowledging that and being honest about it is perhaps an important step, because there is quite a lot of people, and I would class myself in this category, who said, yes, we work well together. Well, we do work well together, but if working well together going to mean something, it's got to deliver outcomes rather than just people feeling like they're working well together. And in some cases, working well together, and then, as Simon says, actually defining the problem in a different way, which would suggest to me that they're perhaps not working together as well as they think they are. And one of the key first things we did in Frontrunner was get a shared understanding. We did an awful lot of analysis to understand exactly what was driving the issues for us, and from that we're able to then start doing design of future improved ways of working, and so we've done 4 key things, or are doing 4 key things. It's still very much work in progress for us, but we've established a fully integrated team and a fully integrated set of roles. So we have a transfer of care hub being developed, and we have a blended set of roles. So we have health and social care staff who have gone through a consultation, who are now working to the same job description, managed by one person. That is the first time that I've managed to do that. I've tried to do it a number of times in my career. This is the first time we've actually done it, and so when that goes fully live shortly, we'll have a single team, single job descriptions, all working to the same ends in our transfer of care hub. We've also around the discharge pathways themselves done work around the Home First team, exactly as Becky described it. We've also commissioned a new intermediate care model to support what goes on outside of the hospital. We're also integrating our IT systems between health and social care to try to help that be less of a barrier, because sometimes it can be, as we well know. And we're also integrating across health and social care how we use our money and try to bring together the finances of this as well. That isn't quite yet gone as far as a single budget for all of this, but that is something that I personally have an aspiration for over the medium to longer term, because we think going forward, increasing integration, increasing single way of working in a total place type arrangement, we think would be a significant positive development and something that we're really interested in developing. But we've got an awful lot of work to do with what we set out to do so far. Delayed discharge is still an issue. We have wards full of patients today who could be elsewhere. There have been times where that's been 2 or 3 wards, so it's definitely better as a consequence of this work. Our length of stay has come down as a consequence of the work that we've done, but we know there's an awful lot more to do. The winter is going to be difficult, and that relationship that we've developed, our shared understanding, will be tested. It's going to be a tricky time. There will be fallout, no doubt, along the way, and I think it's only fair to be honest about that. But underlyingly, compared to plenty of other places that I've worked, I'd say the integration feels more real here, more honest about the scale of the challenge, and a clearer, more consistent understanding. And I think those are the key building blocks to then move forward in a positive way. So enough from me. I think I'll pass back to you, Sally, to continue with other colleagues.
Great. Thank you very much, Matthew. Really helpful and clear example there. And I think particularly the kind of having the courage to sort of hold a mirror up to yourselves locally to kind of go, we might think this is all feeling good and that we're all working well, but actually, is it being as effective as we think it as it is? What's the impact that's having on patients is a really helpful first step to kind of challenge yourself to go further and deeper with integrated working. So really interesting. Thank you, Matthew. We're now going to turn to Jose Luis Fernandez, who's the director at the I know it's CPEC, but I'm trying to remember what the Care Policy and Evaluation Centre. I always get the P's and the E's the wrong way around, so apologies, Jose Luis. Now, we heard Becky talk about the importance of understanding the impact that interventions locally have had. So we wanted to hear from you from a kind of research and evaluation perspective when it comes to discharge policies, discharge interventions, to really kind of get that perspective alongside some of the local perspectives. So over to you, Jose Luis. Thanks for joining us.
Thank you very much, Ali, and thank you for the invite to be here today. It's a pleasure. So yes, just a few points from me, really, which are not specifically about the implementation of the funds, but just the broader context of discharges in England, I guess. And I wanted to start by saying a few words about, I guess, our capacity to assess the problem, to measure, and identify the problem or the outcomes, which I guess would be a more positive way of thinking about this. And just from a very, sort of narrow perspective in terms of the indicators that we have in order to understand what's happening in different parts of the country in terms of discharges, I think it's important to recognize that we don't have a good measure. It is not possible to actually come up with a measure of problems with discharges which is accepted and which sort of covers in the round whether things are working or not. In particular, which specifically identifies issues which might be to do with the interface between health and social care. So we've got indicators about, we used to have delayed discharges, which were highly controversial indicators. We now have a combination of length of stay measures, occupancy rates, and criteria to reside, or numbers of patients who meet or do not meet the criteria to reside. And although those are all sort of relevant indicators that we might want to consider, they behave quite differently. So you can look at the correlation between them. Actually, they're going to behave quite differently. And so, it's about how you combine these indicators in a way that you might be able to identify whether real problems are happening, because you can have very high occupancy rates and that might be perfectly justifiable, or might not indicate problems between in the interface between health and social care. And equally, you might have very high numbers of people who do not meet the criteria to reside, but you might have lots of spare capacity in there. So it's about how you combine these indicators, and actually there is no agreed way of doing that. So that's a problem already. Obviously, there's also problems in terms of the subjective assessment of some of those indicators. And when I talk to, for example, directors of adult social services, they often tell me that some of those indicators suggesting that there are problems with social care, lack of capacity, are often not revealing, what they see as and I think that's what Simon was saying before. These are sometimes highly subjective indicators which, are seen very differently by different parts of the system. The other thing, of course, is that I think we need to recognize that in terms of problems with delayed discharges associated specifically with lack of social care support, those tend to be a minority. The vast majority are not going to be about the lack of social care support at home. And therefore, when you try to analyze, to try to correlate, for example, differences in activity, social care activity locally against these measures of performance or problems with discharges, there's a lot of noise, which is nothing to do with social care, and therefore makes the analysis more difficult. So that's again something that is important. But most importantly, I think, and this is something that you mentioned, Sally, in your introduction, is that it's not just about acute care capacity and throughput. We need to consider this issue on the whole in terms of, for example, the consequences on resources in the social care system. A quick discharge is not always the best discharge. It might have consequences of a very long period of time. For example, if somebody is discharged into a care home and then they stay in the care home for good when they might have been able to go back home, that's a very obvious example. That will have consequences in terms of social care activity and resources, but also in terms of the quality of life of the person. And quality of life is something that is completely out of the data, totally. We don't have any data on quality of life, impact of different ways of organizing discharges. So that's I guess, in terms of, as I say, in the measurement, how can we, the extent to which we can actually understand the problem. But it seems to me that, just making improvements in that would be so important in terms of analyzing or identifying solutions, partly because the solutions are likely to vary depending on the characteristic of the individual being discharged. They will therefore require individual level data so that we really understand for whom these problems are happening and how to put together a solution. Then there are broader, I haven't got much time left, but there are obviously other issues which are very important. Home first, we have been implementing a new model for discharges, which means people are going out of hospital earlier. That means that there are both differences in terms of the support that they require post-discharge, but also the capacity of the system to think about changing those support packages as they recover post-discharge. That's something that we need to bear in mind because it has implications in terms of capacity of the system, reablement, rehabilitation, etc. There's also issues about the interface between this and the broader commissioning of social care and the extent to which broader commissioning is coordinated between health and social care stakeholders. To what extent is that working well? What is the role locally of CHC, which varies, we know, a lot across the country, and that again is going to have an impact in terms of not just how much is left to the social care system to pick up, which varies a lot, but also in terms of the quality and the prices that they need to face, because there is direct interrelationships between commissioning decisions in the NHS and social care. And finally, there's an issue about the complexity of the at the almost geographical or organizational level. We know that we did some work some years ago looking at the impact of the numbers of local authorities that hospitals needed to deal with, and that seemed to lead to differences in lengths of stay. So, how do we organize this in a way that is best from a geographical perspective? Are ICSs going to solve that problem by looking at things at a higher level or not? When sometimes actually there's variations even within small authorities in terms of, for example, availability of services. But I'll leave it there. Thank you very much.
Great, thank you very much. Really, really helpful. I think in particular, really bringing to life where other colleagues have talked about the importance of being clear about your data and what your data tells you. I think people outside the health and care system must think, hang on a minute, surely it's really obvious what delayed discharge is and what's causing it and how many, but actually you were really clear about the complexity about even what is the measurement, what are we missing from the measurement. So really, really helpful. Thank you for that. We have got some questions coming in from the audience. I was just going to ask one before we then come to the wider audience, which was really about leading off from that data point. So Becky and Matthew, you both talked about the importance of like being clear about what's the kind of shared data and what's the story that the data tells you. I'm interested about, do you have any reflections on how you manage the conversation where clearly there is disagreement? To begin with, there must be disagreement about what the data is and what the data tells you. So how have you managed that conversation where you've been able to disagree and get beyond the disagreement in a way that's then kept the local partnerships kind of moving in the right direction? So I guess, yeah, just to be able to share a bit with our audience, because I can see from the questions we've got a lot of local practitioners who I think will be interested in how have you been able to kind of move through that. Do we understand the problem? To yes, we do, and that's required a bit of storming as a team, but we're now through it. So Becky, you've leapt in with your hands up, keen to talk about that. So thank you, Becky.
Thank you, and it's a really big topic of conversation, isn't it? And I think one of the things we always focus on is the individual at the end of the the receiving end of the care, and always try and focus the conversation around the residents and doing the right thing by our residents. But it is about coming together in workshops. I think sometimes we do in times of pressure start to sort of blame each other, and these are yours, these are ours, and you've got to come away from that conversation, these are people, and that really focuses the mind when you pull it back to the fact that these are people. But it's about looking at the data together. And I think once you're looking at things line by line, and unfortunately sometimes it does come down to having to look at things line by line, and looking at where the gap is. You can't come up with a solution to flow if you don't know where your gaps are, and some of it's that high impact change model as well, looking at what element of that you're trying to resolve. But I think it's as Matthew said earlier, it's multifaceted, but one, it's having that person at the end of it as your focus, looking at the data together, because I think you can interpret it differently if you're not, and then agreeing what actions each other's going to take, and then agreeing one version of the truth. And if you're all happy with that, it's not always a comfortable read, don't get me wrong. You can look at things and go, oh, blooming heck, we've got 12 people waiting for social care solution today. But it just concentrates your mind and you work on it together. But come together, look at it together and agree actions together, and then come back and look at where you've got to, would be my thoughts on that one.
Thanks, Becky. Matthew.
Yeah, thanks, Sally. I mean, I would concur with Becky. I'd like to say there was a magic answer to this, and there isn't. It's hard work, it's relationships, it's, you know, going through it in a detailed way, and an acknowledgement that you don't always get it right. There will be still on our list today people who say, well, I'm not sure about that. I think that's not quite what I would say. So there's you know, when you've got a whole bunch of people involved, you're going to get differing views, and in some respects, good that you do, because that will challenge people and mean you're likely to get to a better answer ultimately. But it can be obviously frustrating along the way. What I would say, a bit like I said earlier on, and Becky's reiterated, is, you know, to properly get a handle on this, if you're spending a lot of time arguing about the data and whose issue is it, then that's a distraction technique. That is not going to do anything to help you solve the issue. So if I personally hear of that, I am on it pretty quickly, because it just is wasted effort, and we haven't got a lot of time or energy to waste on a problem as complicated as this. It's everybody together, get over it, get the data agreed, and move on. And certainly the work we've done, we were supported on Frontrunner by a consultancy who helped us with that, and created a data pack, which I think surprised some people about some of the things that it said, because when you work in the system all the time, you sort of see the list of patients, you go, oh, yeah, I can see that. But underneath it, you know, some of the issues around length of stay, around some of the ways that things are working or indeed not working, did surprise people who have worked in this field for 10, 15, 20 years. So I wouldn't underestimate the power of it if you can get it done as well. So hopefully that's helpful.
Thank you, Matthew and Becky. Really helpful reflections. So I'm going to come to Q&A now, and what I'll aim to do is take a couple of questions at once, and my team behind the scenes will enable mics and cameras to be turned on for the people we're coming to. So take a couple of questions and then put those to the panel, and then hope to do that a few times round. So the first couple is Alex Bax. I've seen, Alex, that you've asked a couple of different questions about homelessness, so I'll leave you to pick which one would be your preferred, and then Alison Freud will come to those two first. So Alex, you're downstairs, Alex.
I am. I'm foolishly here in the cafe, but it's a convenient spot for me this morning. So thank you for your coffee, Sally, as well.
No worries.
Thank you. Yeah, really interesting. I guess so. Perhaps to bring those two questions together, I guess from the perspective of patients with nowhere to go, we always worry that the whole framing of hospital discharges is making the problem a problem of the patient's causing a problem because they're in the wrong place of the system and that it's their fault. And whereas actually for many of our patients, we see a hospital admission as a fantastic opportunity for change. And someone's already said that a longer admission can sometimes be really, really crucial. And then when we see some parts of the system in winter, actually the overwhelming pressure to discharge just forces some pretty awful things to happen to patients in some places. And that just is hard. But I guess the question is whether this framing of discharge, which seems to be such a system flow bed management pressure, can ever be reconciled with a kind of much more patient-centered perspective on people's needs. And does a system under the pressures we're currently under, do patients' needs really just get squeezed out by the system pressures?
That's a profound question for not quite 9 a.m. in the morning or just after. We'll come to Alison's question and then bring all of that to the panel. I see Matthew's already keen to respond. So Alison, thank you.
Yeah, hi, good morning. Just really interested I don't know how much you know about these, but the personal health budgets, one-off personal health budgets to aid discharge, there's real growing evidence that these are helping to reduce length of stay in patients in pathway 0 or 1, I think, and I'm involved in this area as well, so obviously I've got an interest in this question. parts of the country and some trusts have really adopted this. It was introduced during COVID, and then it's obviously had varying levels of implementation really. But there is really growing evidence this is reducing length of stay by at least 2 days per patient. And if this was scaled up across all trusts, then it could only be an extra benefit. It's not going to be the panacea, but it's another thing in the toolbox really. I'm interested in what you see the barriers to this being implemented really, and any suggestions going forward.
Great, thank you. So 2 questions there from Alex and Alison. So Matthew, I think I'll come to you for Alex's question, and then for Alison's and Simon's popped in as well. And I think Alison's question is both about the specifics of that model, but I think also it might come to Simon and Jose Luis about more generally about how do you identify what works and how do you support implementation of that across the system. But Matthew, let's come to you. Thank you.
Yeah, thanks. I mean, really good question from Alex. I mean, the short answer is I think there is a risk that they can. I think, you know, we do get a bit tied up into numbers and systems and governance and process and thinking, right, well, we've got a list here, and you forget sometimes that that's a bunch of people with their own specific needs, and if you do forget it, it comes back and bites you, because often you can get the rest of the process all sorted out and then you realize actually it's a person and that they have got a family, or possibly not a family, but have other needs. We've definitely got a homeless issue building here in Croydon, and that has definitely added to the pressure. So I mean, I think the short answer to Alex's excellent question is it is a risk, and I think it's beholden on all of us to, you know, remind ourselves regularly that, you know, what we're doing this for is to, you know, offer the best to the patients whilst they're with us, and then, you know, when they're not patients and they're discharged, that similarly they get that same level of appropriate care, and that is a big message that, you know, leaders need to give, but also practitioners need to remember at all times. However difficult that is, because of the pressure, you sometimes get, you know, pushed into thinking it's not quite that. Ultimately it is, and that's absolutely our responsibility to focus on that.
Thank you, Matthew. Simon.
Yeah, I was going to agree with Matthew, and one of the local authority directors of adult social services that we spoke to, and I was just going to read out, they said, you know, the more we talk about acute beds, care home beds, people forget they're people that we're talking about, and they're probably in the most traumatic part of their lives. It's not a transaction just to get them out of hospital, and that I think came across really strongly in the research. I don't know, I'd be interested in Becky's thoughts on this, about whether there is a difference in attitude and a difference in culture and perspective between local authorities and DASs and the social care side and the acute medical side, because I think there's an assumption actually amongst lots of DASs that I speak to that there is that difference in culture and behaviour, and perhaps some of that underpins some of the relationship issues that we're talking about. But yeah, it definitely came up in the research. And of course, you hear it an awful lot when you talk to carers and carers and families and individuals about, you know, the thing that matters to me is getting home and getting independent and going back to living my life the way I wanted to. And the risk that actually, if you want to get people out of hospital quickly, you send them down a route that gets them out most quickly, but actually may impede their possibility of independent living in the future.
Thanks, Simon. We've got a great question from Joe Andrews that I was going to come to shortly about, is there a difference in the perception and understanding of risk, which I think picks up that attitude point. So Becky, I'll come to you with that question in a moment, but Jose Luis, you wanted to come in on this first pair of questions.
Yes, I was just going to make the point that we know that the system is under significant pressure, and there is a lot of concerns about trying to get increases in throughput in the hospital. In that context, it seems to me that it's particularly important that we actually measure the quality of life implications of the decisions that are being made. And at the moment, there is no way in which we can say anything about that. So as an academic, I guess it's fairly predictable that I say this, but I think it's really important that we actually measure quality of life of people going through different discharge routes, post hospital discharge.
Yeah, completely agree, Jose Luis. Becky, we'll come to you, and then I'll move on to the next set of questions where I'm going to come to Melanie Hayward and Joe Andrews for the next set of questions. But Becky. Thank you, Sally. And I think in terms of risk and cultures, I think there is a perceived difference, but I think that difference is the gap's closing a little bit in terms of us working through our ICSs and working as a system. We are understanding each other's pressures, and I think sometimes the pressures trigger your behaviour. I think the risk question is really interesting, and I think there's something about the breadth of social care and the understanding of what social care actually does and responds to. So hospital discharge is just one part of social care, and so it's understanding all the different routes and pathways through the work that we do. I think what's been really interesting and what we've picked up through the industrial action over the last 12 months is that there are different levels of risks around different sort of seniorities of consultants in hospitals as well. So we've seen sort of different spikes in discharge. And I think there's been a bit of an encouragement around what level of risk are we willing to take, focusing on the fact that when somebody's in hospital and they're about to be discharged, they're probably, as Simon referred to it, some of the worst points in their lives, and actually it's the worst time to assess them. We need to give people chance. So the discharge to assess is really important. But I think just understanding what people's needs are as they're discharged from hospital is fundamental to getting it right. I mean, we all know the mantra that 2 weeks in a hospital bed equals about 10 years of muscle deterioration, and it's being mindful of that and just taking that risk around the discharge, I think. But I think there is a difference in culture, but I think that's based on the pressures that we're all under, and we are working very hard in that space to overcome some of that. Thank you, Becky. And we'll carry on picking up that point about risk, I think, as we go. So if I can ask Melanie Hemwood, your question about carers in particular kind of jumped out for me, and then Joe, we've already begun to talk about risk, but your question about differing approaches to risk. So hopefully one or both will just magically appear on our screen.
Yeah. Can you hear me?
Yeah. Hi, Melanie.
Hi. I had two questions, if I could briefly just flag both of those. I mean, the first point was about carers in the sense of family carers, unpaid carers, who seem to be quite absent from this debate, and are obviously absolutely fundamental to it in supporting the discharge of people, but also avoiding admission. So I think it's a question about how do we ensure that, you know, those voices, those interests are reflected within any strategy. And I had another question which isn't really related, but it's about, you know, the importance of prioritising recovery-based support and really meaning that rather than just rebadging beds, you know, so really looking at how do we use beds that are recovery focused. And I'm particularly interested in, you know, how commissioning specialist provision in the community fits in with this. So looking at specialist support for people with dementia, but also with other complex needs, how that becomes part of the package, because I think it was interesting to me that didn't emerge as a key theme in the research, and I think that's fundamental. So I'd be interested in reflections on both of those points. Thank you.
Thank you, Matthew. And then Joe, we'll come to your question before putting both to the panel. Thanks, Joe.
Lovely, thank you, Sally. And yeah, and thank you, Becky, as you said, has already started picking up on some of this. But I think for me, there are three ways that I see risk playing out, and it'd just be great to understand how systems are approaching this. The first is that kind of, from the individual's perspective, the risk of discharge versus not discharge, and how we manage sort of the multidisciplinary team's understanding of that. So what's the risk of keeping somebody in one space? There's then the risk of discharge versus not discharge on the rest of that individual system. So how do organisations share the level of risk that they are carrying? And then finally, how do they understand the level of risk that they're asking other organisations to take on in order to respond to that escalation? It'd just be really good to understand how those conversations are playing out, because for me, it feels like a really important part of that single version of the truth, and having an honest conversation about how do we work together to address the needs of the patient within the constrained system.
Yeah. Thanks, Joe. I think that's a really great question. And for me, it particularly sparks a couple of things. One is we've just been doing a piece of research actually on why for the last 30 years there's been a vision to shift care away from hospitals into the community, but it hasn't happened. And actually, we think one of the reasons it hasn't happened is this different approach to risk, not just between health and social care, but actually between the acute sector, primary care, community health and social care. So it really resonates with us as we're just beginning to finish that piece of research. And I'm also remembering a meeting I had with Adam Doyle, who's the chief exec of the ICS down in Sussex. And he said what he's worried about in ICS is he's got a lot of data about the impact and risk of a decision on some parts of the system, but he's completely blind to the risk it causes elsewhere in the system. And it means they can't make good decisions because they just can't see the total impact of the decisions they're going to make. So the risk is that they end up making the decision which is better, in inverted commas, for the part of the system they've got the most visibility of, rather than thinking actually from a system as a whole, do we know what's happening? So really good questions. Simon, you I think we're going to leap in on the carers question, but also please do on the risk as well, and then Becky will come to you. I'd also be interested in Matthew's perspective about that kind of different views of risk. So we're having all of the panelists are keen on these couple of questions, so Simon, please lead the way.
Thanks, Sally. Yeah, I'll certainly speak to the carers question. So one of the things we did as part of the research was speak to national and local health watches, because we wanted to understand what sort of concerns arose from patients and families about discharge. What was really interesting is that Health Watch told us that they got relatively few complaints and concerns about delayed discharges. They got more complaints about early discharges. So patients and families, particularly families, were more concerned about the fact that people were being moved out of hospital too quickly from their perspective than that they were being sent out too early. It is also the case, I think, that health watches tend not to be involved very much in how the discharge funding that we were looking at was being spent. Sometimes they were on committees sort of ex officio, but typically because of the speed that the plans needed to be made, health watches didn't tend to get much of a sort of strategic say, and that also applied to other sort of really core groups. Sort of VCSE organisations felt that they didn't get much of an opportunity to be engaged with how you might sort of more creatively think about sort of discharges and what you could do about them. And social care providers also told us basically that they tended not to be involved. And again, it came down to this. Systems having to move quickly with short-term money, and so they went to the usual suspects really in order to make decisions.
Thanks, Simon. We'll go to Becky, then Jose Luis, and then Matthew.
Couldn't find my mic button then. Just very briefly on carers, I think we cannot get away from the fact that they're the absolute bedrock of social care. Last year, ADAS really made carers the focus for the year, and without unpaid carers, family carers, and people often don't recognise themselves as carers. I've certainly been in that situation myself, where I've been a carer for my own husband, and I would never have said I was a carer. I'd have just said I was his wife. So there's something around making sure people understand what's available to them. That's certainly in our winter plan, our commitment to carers, and making sure the direct payment support is in place for them. Social care would collapse without carers. There is no doubt about it. So it's crucial that we do make sure we focus on implementing our plans around carers. Just around the risk that Joe raised, there is definitely a level of honest conversation around risk that needs to happen, and happen through MDTs, because whilst we're all agreeing the home first principles, we need to recognise what that means, and that can mean that people come out of hospital with greater needs than maybe they did previously, but that's the right thing. The right thing to happen is to get people home and independent. and people, no disrespect, Matthew, nobody wants to be in hospital. Why would you want to keep people there? We need to recognise that we've got people as well as we can at that point, and what can the community do? So the things that we've done in terms of managing that risk is we piloted a community transfer of care, so trusting our health professionals to refer people who haven't got an existing package of care for community reablement for up to 4 weeks is an example of something that we're doing, saying we share the trust, we respect your medical view, and so I've put that community transfer of care in place. I think we're possibly missing the importance of occupational therapy in this conversation around community OTs and what they can do to support discharge, and making sure we've got that support in place, and then just looking at the home assisted reablement. So I think the risk to the person is being mitigated by what we put in the community. We just need to be mindful what the community is, and that the community is expanded as much as we possibly can, and the risk of not discharging is massive. People end up in that loop of being readmitted, and the system ends up, the cycle of people going through the system because we haven't grown the community in the right way. So managing loads of different aspects of risk, but I think trusting each other to make decisions and then respecting each other's decisions is quite crucial.
Thank you. Here's Eloise.
Thank you. Just a couple of quick points. One on intermediate care and step down there. So, Melanie's point, I think it's very important. I think one of the challenges we have when trying to examine this question is what do we mean by intermediate care? What do we mean by those types of services? Because quite often they vary a lot in the extent to which they are truly, for example, aimed at rehabilitating somebody. In particular, community services, so reablement services in the community often are just pure home care, and so it's difficult to understand their role and how well they work because of that. In terms of risk, I think something that we see quite often is this complaint that actually the package that is recommended by the assessors in the hospital is way too expensive. It's double-handed care, 3 hours a day when that might not be required. This is important because I think a lot of what we're talking about means that in order to improve hospital discharges, we need not necessarily to provide a lot more services, but to improve the way we organize the information that we gather and how we organize the discharge. And for example, the extent to which assessments which are carried out in the hospital might be reviewed by assessors in the community in order to tailor those packages better to the needs of the person in their own homes. So it's about the house, not so much about how much we provide sometimes. And I think that's an important lesson.
Thank you. And then Matthew.
Thanks, Sally. Yeah, I mean, I build on what colleagues have said. I won't repeat, but what I would say in answer to Joe's question, nice to see you again, Joe, that one of the benefits of the blended role approach that I talked about is that you try to get a consistency on that risk assessment, because you've got people doing it in the same way from different perspectives, because there are definitely different levels of risk being taken from the perspective that people look at it from, and we work in an acute and community trust here in Croydon, and I know if I talk to my community teams, their appetite for risk is definitely different to talking to some of the more junior team members who are based on the acute side, for example. So it definitely is a thing. Joe's absolutely right in that regard, and the blended roles approach is one of the benefits of it. There are a number, but one of the benefits is it takes away a little bit of that, well, we've got two different views going on here, because we are trying to create the same view and a consistent view and a consistent approach. If I can add to that, Sally, very briefly, in answer to one of the previous questions, because it's pertinent, which is the level at which those staff are. They're band sixes, and they can do assessments. There was a question about, do they do care assessments and mental capacity act assessments? The answer to that question is yes, they can, because that we think is important for them to actually do the job that we're asking them to do. So these are, people with authority and experience they're just working in a different way, and we'll see how that plays out because we've just finished the consultation. We're just going into that process now.
Thank you, Matthew. Really helpful. I'm going to try and push my luck and try and squeeze one more question in from Paul Nazarek. But we are coming into the last 5 minutes, so I'm going to ask that Paul's question is short, which is why I know we can come to Paul, but also if the panelists can just do some quite quick reflections, I think that would be really helpful. So Paul, hopefully you will be magically on my screen. Are you there?
Yeah, I think so.
Right,
Sally.
yeah, we can hear you. Perfect. Hi,
Great.
morning.
Hi, great to see you, Sally. Great to see you, colleagues. So yeah, I'm currently the interim social care and local government ombudsman, actually. So really encourage all the comments about the patient experience in this and the family experience. We see quite a lot of stuff that relates to this. But my question, Sally, is about mental health. So really just interested whether the same lessons that we're talking about more broadly apply to mental health, or there's particularly learning from colleagues about mental health discharge and pressures in mental health. Thanks, Sally.
Great, thanks, Paul. I thought it was really important that we have some time on mental health because we haven't been talking about it much yet this morning. So I think I might come to Becky first, then to check in on Simon and Jose Luis to see if there's anything from research, and we'll come to you, Matthew, to have the final word on it. So Becky.
Thank you, Paul. Mental health is a particular issue at the moment for us. We're seeing a lot of people needing support around mental health. We're seeing an increase in the numbers coming through our doors, needing either low-level mental health support to prevent any further distress, or people who are under our Black Country Mental Health Foundation Trust as well. What we are focusing on is trying to work within the market to find the right care for people with mental health, making sure that they are admitted to our Penn Hospital rather than our RWT acute hospital. We've really strengthened our AMP hub and our mental health team throughout the last 12 months, but there is a gap. There absolutely is a gap, and there's no point pretending it's all going smoothly. The demand that we're seeing in the system, trying to grow the market to support people who need us in that space, has been really tricky. What we have done is looked at through our One Wolverhampton partnership. We've looked at, I don't like the phrase frequent flyers, but I can't think of any other way to describe it on my feet. But tried to look at the reasons people are attending the acute hospital with mental health reasons, and seeing what we can do to intervene with our Black Country Mental Health Trust, and how we can refer between us rather than people not ended up in the right place, really. But it's a work in progress, and we have found people have been admitted to our acute hospital when actually they need different levels of support, and it's the only place of safety for them to go. So we're working in a commission space at the moment to see what we can do differently. But it really is a challenge, especially around winter and the Christmas period when people do tend to struggle a little bit more. So a big challenge for us. Hopefully it's a bit of a watch this space in terms of where we get to.
Thank you, Becky. Because of the time, I'm going to just jump straight to Matthew, who had popped his hand up for this one. So Matthew, your reflections on this.
Yeah, I mean, I'll be really quick to just say, I mean, the learning is that it's much more complicated even than the physical health space. If I look at the discharge challenge in mental health, the length of time, the complexity of the process, the issues with capacity are, I would say, even more difficult than that with physical health. So my learning would be, we've got to get the first bit done first, but we absolutely need to have a focus on mental health. It is an area, I think, of real concern, and I think Paul has put his finger on an important topic, one that perhaps we should have picked up earlier, because it is a whole lot harder than the other aspect, and that is difficult enough, as we've discussed.
Great, thank you, Matthew. I think really good question for us to end on there. So thanks, Paul, for the question. And it feels like it's been a jam-packed last hour and 15 minutes that's gone by really quickly. I'd like to thank our panelists, Simon, Becky, Matthew and Jose Luis, for sharing so kind of openly their insights, either from the research or from the local practice they're going through, and in particular, what's working, what's difficult. But I think what's kind of been a core theme is it is extremely complex. There is absolutely the will to try and improve discharge, but that requires long-term thinking and planning. But you can think long-term with some agility to respond to what might be inevitably short-term opportunities or pots of cash that that get thrown in our direction as well. So that balancing long-term thinking with short-term agility, really, really important. So thank you all very much for joining us today. Thank you to our panelists. Thank you to our audience for joining. We're obviously beginning to come to the end of 2023, and as we come into 2024, likely election year, the King's Fund, we've been particularly focusing on 3 key priorities in an election year. One is how we can help bolster services outside of the hospital, obviously of which today's conversation has been a clear indication of why that's so important, that connection between hospitals and those services outside. Supporting the health and care sector to be a really attractive career so we can retain the staff we have, and how we can reduce some of the biggest risk factors that cause ill health across the country. So you'll be hearing more from us on all of those 3 issues across the next year or so. So thank you very much for joining us this morning. It was great to have you all with us, and have a lovely day. Take care. Goodbye.